Sir.
It's a pleasure to conclude this enriching session. We have seen how electrophysiology unravels the mysteries of retinal disorders. And now, let's bring it all together with some real world cases where electrophysiology was truly indispensable. Let's go to case number 1. A 35-year-old male fireman presents with progressive distance vision for 5 years. His color vision test shows he could only read 17 out of 23 Ishihara plates in both the eyes. The best corrected visual acuity was 20 by 40 in his right eye and 20 by 20 in his left eye. The anti-segment examination under slit lamp was unremarkable. Here you can see the fundus image of the right and left eye. While grossly the fundus appears normal, one can appreciate subtle RP changes along the arcades. Also, the foveal reflex was appearing dull. So what's next? While the structure looks fine, could there be a functional issue? Here is the autofluorescence image. Notice the granular hyperautofluorescence along the arcades, also in the peripapillary region. And this kind of hyperautofluorescence was symmetrical in both the eyes. So this pattern raises a suspicion of inherited retinal dystrophy or some kind of toxic retinopathy. Now let's examine the OCT scans. We see a bilateral subretinal and intraretinal hyporeflective spaces. The intraretinal hyporeflective spaces were localized to the outer plexiform layer and outer nuclear layer. And all these features in both the eyes were bilaterally symmetrical. To further investigate, we assess the patient's detailed history. There was no history of parental consanguinity, there was no family history of similar illness, and no significant medication history. However, there was a history of tobacco addiction. He was treated as a case of central serous chorioretinopathy earlier without much benefit. Fulfilled ERG reveals subnormal cone and rod responses in both eyes, measuring approximately 70% of the normal lab standards of ERG amplitude, indicating a global photoreceptor dysfunction. Additionally, we performed electrooculogram, which revealed an absence of light peak, suggesting severe RPE dysfunction. We perform genetic testing. Whole exome sequencing confirms an autosomal recessive mutation in the BEST1 gene. So what's the takeaway? Remember, a key distinction in electrophysiology is that in best vitiliform macular dystrophy, EOG is severely reduced, but ERG is relatively preserved. However, in autosomal recessive bestrophinopathies, both EOG and ERG are severely reduced. Next, we'll discuss two boys, both 8 years old, with a best corrected visual acuity of 20 by 100. They present with complaints of blurring of vision along with very minimal nyctalopia. Interestingly, both the boys share a similar looking fundus appearance. This raises the question, are we dealing with an early onset inherited retinal disorder? So let's analyze their imaging and electrophysiological findings to uncover the diagnosis. Here you can see the color fundus photograph, autofluorescence and OCT of patient number 1. On a deeper look, the autofluorescence imaging reveals three key features. First, presence of macular atrophy with classical peripapillary sparing. And also, you can also notice there is a classical amoeboid pattern of atrophy extending throughout the fundus. We perform the electroretinogram, which shows both rod and cone systems affection with a predominant cone dysfunction. Similarly, when we examined boy 2. This is the color fundus and autofluorescence imaging of boy 2. On cursory look, you will also see three classical autofluorescence finding in our second patient. It reveals macular atrophy with peripapillary sparing. However, a distinguishing feature is that there was presence of fishtail flex. Interestingly, when we performed the full field ERG, it showed a near normal scotopic response with only a slight cone affection, which was approximately 30% of the 30% reduction of the normal left standard. This subtle dysfunction suggests that a different disease spectrum compared to the other boy. We went ahead with genetic testing, and genetic testing identified distinct diagnoses for both the boys. Boy 1 had RDS12 related Leber's congenital amaurosis, explaining the early onset visual impairment and nyctalopia, and boy 2 had ABCA4 related cone rod dystrophy, which aligns with his imaging and electrophysiological finding. As we have seen throughout these cases, electrophysiology plays a crucial role in unraveling the complexities of inherited retinal diseases. It allows us to detect functional deficits even when structural imaging appears normal, guiding us towards the correct diagnosis. However, it is essential to remember that electrophysiological tests should never be used in isolation. Instead, they must be interpreted in the context of clinical findings, multimodal imaging, and genetic testing to form a comprehensive diagnosis. Thank you very much.